All right, let's talk about one of the most high-stakes life or death decisions you'll ever make as a nurse. Defibrillation. Get this right, you save a life. Get it wrong? Well, that's exactly why we're here. We are going to make sure you're ready to make that critical call in seconds, especially for the NCLEX. Okay, put yourself in this scene right now. You walk into the room, your patient is totally unresponsive. You look up at the monitor and you see this chaotic mess of a waveform. You check for a pulse, there's nothing. Your own heart starts pounding, right? This is the exact kind of scenario that NCLEX throws at you. So, what is your very first move? If your gut screamed defibrillate, you are definitely on the right track. But let's get super specific about what that actually means. We're not just shocking the patient for the sake of it. We're delivering a really powerful and, this is key, unsynchronized shock. And its mission is very, very specific: to stop the two deadliest rhythms out there, VFib and Pulseless VTAC. Now, this right here is a huge myth buster. We are absolutely not jump-starting a heart like it's a dead car battery. That's Hollywood stuff. A better way to think about it is this. Imagine a heart in VFib is like a computer that's completely frozen, just spazzing out with electrical chaos. Defibrillation is the hard reset. It literally stops everything for a split second, hoping the heart's own natural pacemaker can reboot and take over again. And why all the urgency? Why are we running down the hall with this machine? It all comes down to this number: 4 to 6 minutes. That's your window. After that, without blood flowing to the brain cells start to die, and that's irreversible. Every single second you waste means the patient's chances of walking out of that hospital are plummeting. So this leads us to the absolute core of any code blue: making that critical decision. To shock or not to shock? It sounds like a simple yes or no, but man, the consequences of getting it wrong are just devastating. When a patient's in a pulseless cardiac arrest, their heart rhythm is going to fall into one of two buckets. It's either shockable or it's non-shockable. There's no in between. And knowing which is which isn't just a good idea for your exam, it's a fundamental, non-negotiable part of being a safe nurse. Okay, this table right here, this is NCLEX Gold. It basically lays out your entire thought process. Look at the pattern. VFib and no pulse, yep, you shock. Pulseless VTAC, you shock. But then you get to asystole, the flatline, and PEA, pulseless electrical activity. They both have no pulse, but shocking them does absolutely nothing. For these two, the only answer is amazing, high-quality CPR and pushing epinephrine. So here's the bottom line. The one thing you need to burn into your brain for the NCLEX. You ready? Only VFib and pulseless VTAC get shocked. I'm going to say it again because it is that important. Only VFib and pulseless VTAC get shocked. That's your mantra. All right, pop quiz. Let's see if you can spot a classic NCLEX trap. Your patient is in AFib. They're unstable, their blood pressure is in the toilet, but, and this is the most important part, they have a pulse. Do you grab the defibrillator and get ready to shock? Think about it. This is a really crucial distinction. The answer is a hard no. You absolutely do not defibrillate. For an unstable patient who still has a pulse, the procedure is called synchronized cardioversion. You have to know the difference, and this table lays it all out. The big takeaway? Defibrillation is for patients with no pulse, and it's unsynchronized. Cardioversion is for unstable patients with a pulse, and you have to hit that sync button so the machine shocks on the R wave. And since they're awake, you bet we're going to sedate them first. Okay, so knowing when to shock is half the battle. Now let's nail down the step-by-step action plan. The NCLEX loves to test you on the correct sequence of events, so let's walk through the life-saving order of operations. This sequence is everything. Notice, what's step 1? High-quality CPR starts immediately. While that's happening, someone else is grabbing and attaching the defibrillator. Then you analyze the rhythm, and if it's shockable, you shock. Now look closely at step 5. This is where people mess up. You immediately get back on the chest and resume compressions for 2 solid minutes. You don't stop to check for a pulse, you don't hesitate, you just go. Here's a super simple way to lock in that algorithm. Just remember this order of priority: shock, CPR, meds, reassess. If the rhythm is shockable, the shock comes first. Then right away, 2 minutes of hard and fast CPR. After that, you can think about meds like epinephrine. And only after those 2 minutes of CPR are up do you pause to reassess. Shock, CPR, meds, reassess. All right, now for my favorite part, the NCLEX traps. The little things that can trip you up. The exam isn't just about what you know, it's about whether you can apply it safely. So let's make sure you don't fall for these common mistakes. These are the absolute do-nots of defibrillation. We already know we don't shock asystole, there's no electrical activity to reset. And you never delay a shock to get IV access. Electricity is the priority, period. We've talked about not checking for a pulse right after the shock, and this last one is tricky. You never hit the sync button for VFib. Why? Because VFib is total chaos. There's no organized R wave for the machine to sync with. Hitting sync just wastes precious life-saving seconds. Safety for your patient and your team is absolutely non-negotiable. First, the chest has to be dry. Water conducts electricity, and you don't want the shock arcing across the skin. Rip off any medication patches, they can block the current and cause nasty burns. If you see a lump from a pacemaker, make sure you place the pad at least an inch away. And the final, biggest safety check. Before you push that button, you yell loud and clear, "I'm clear, you're clear, we're all clear." Make sure nobody is touching that patient or the bed. Whew! We've covered a ton of ground, so let's lock it all in with a quick rapid-fire review and one last scenario to put your clinical judgment to the test. Okay, let's run through the memory anchors. No pulse? Your brain should immediately think shock. What rhythms get the shock? Only VFib and pulseless VTach. Is defibrillation synchronized? Nope, never. What do you do right after the shock? Get back on the chest immediately. And what's the big picture principle? Urgency. Shock early and shock fast. Okay, last scenario, and this happens all the time. You get the AED on the patient, it does its thing, analyzes the rhythm, and then that automated voice says no shock advised. What is your number one immediate priority action? The answer, without a doubt, is to immediately get right back on that chest and resume high-quality CPR. When the machine says no shock advised, it's telling you the rhythm is not VFib or pulseless VTach. It's almost certainly asystole or PEA. And for those rhythms, the only thing that's going to help is continuous hard and fast chest compression. So what's our final takeaway here? Defibrillation is an incredible, life-saving tool, but it only works if you use it on the right rhythm, at the exact right time, and without a single moment of delay. Your ability to see the cues, make the call, and act with confidence, that is what turns this machine into a miracle. And that's what's going to make you a fantastic, safe nurse.